welcome to Cornea Frontiers. This is the maiden edition. And today we have a very special guest, Dr. Kevin Chan, all the way from the United States. And today we're going to be discussing some contact lens options for myopia control. First off, we'd like Dr. Kevin to introduce himself and tell us a little more about yourself.
Sure. Thanks, everyone. Thank you for having me for joining this podcast. It's my great pleasure and honor to be here and to share my experience with all of you. So to start off, let me just introduce a little bit about myself. My name is Kevin Chan. I'm based in Virginia in the United States. And I'm currently doing myopia management, specifically in a practice solely dedicated for providing myopia treatment for young kids. And my academic background started in Boston, Massachusetts. I did my optometry degree in Boston, and then I did a special training for orthokeratology in the Oregon on the West Coast in the States. And then I moved down to Virginia to start my career. And then starting about 5 years ago, and I've been joining a company called Treehouse Eyes, which specifically doing myopia treatment for children. So I've been with the company since then for about 5 years now. So again, I'll be happy to share my experience today, and then hopefully we'll have more clinician and practitioner to be able to get involved in serving myopia treatment for young kids.
Thank you so much. What an introduction. So you've had quite a journey into myopia management. Briefly, can you describe what I see? You have a Doctor of Optometry degree. You also have a master's in vision science. Can you describe what your interests are aside from just myopia management? Any other clinical interests that you have?
Sure. Yeah. So besides myopia management, I'm also interested in ocular disease and pediatric in general. Because I also have a couple years of background doing primary eye care, serving all patients in different age group and demographics. So I know pretty much how to serve patients from different age group. But my core interest is more into serving kids, and because I found that it is very personally rewarding and also helping patients to see for the next 10 years or so, even longer, could be very fulfilling for them, because we're serving a different demographics. And I found that pediatric is especially challenging, not for every practitioner, to be honest. But at the same time, I found that if you make a real difference for those young patients, the family will follow you for the rest of their life.
Wow. You seem to mention pediatrics a lot. Since you work more with children, your practice is dedicated to myopia control. So I assume you have mostly children patient base, or your population patient base is mostly with children. Do you have any research interest? Because it's funny how we met. We actually met through the American Academy of Optometry Clinical Investigation Certification Program. And I remember going through the modules of the program, and when we discussed our interest, and you spoke about myopia control, and then I realized you had given a TED talk on myopia control. I went back and watched the video and watched some other lectures you had given. So why myopia control specifically? Why does that spark the interest in you? Is there any specific reason?
Yeah, so that's a really good question. I think back in the old days when we were both in optometry school, I think the field of myopia management doesn't even exist at that time. And I recall that when I was in school, I wasn't even taught about the subject of myopia management. I think at that time, myopia is just being understood as the vision correction, nothing to do with any ocular disease or any pathology. But as time goes by, we're seeing technologies evolving, and we learn more about myopia as a whole, and we understand that it's more than just vision correction alone. In fact, it's more to do with the physiologic changes over time, leading to axial elongation. So as a result, we are seeing that myopia management in the past 5 years has been booming, at least in the United States. I'm not sure about South Africa or Africa in general, but in the United States, more and more practitioners are getting information almost on a weekly basis, knowing about different updates of myopia management. So I think this field has been, really growing significantly, and in a way that, not every specific field in optometry can catch up with. So I think seeing this is really fulfilling, because we know that this is going to be the future for eye care, in my opinion.
I totally agree with you. Again, just as you mentioned, myopia control coverage is not totally universal in eye care world. What obtains in the United States is quite different from what obtains in Africa, in Europe, and other parts of the world. Also, certain strategies may not be widely available. I'll just give you a brief background of where I practice, so we can steer this discussion going forward. So I practice in Nigeria, in Abuja, the capital of Nigeria. So I'm also involved in a bit of myopia control, orthokeratology, multifocal contact lenses. But there are certain interventions that are not widely available. For example, we don't have the MySight lenses here. There's certain devices that are not widely available. Basically streamlined to spectacle options, bifocals, progressives, which may or may not give such efficacy as multifocal lenses or myopic defocus lenses and things like that. Now, coming from that background, it's not so common to find practitioners who are engaged in myopia control. So the essence of this podcast is to, first of all, enlighten practitioners about the options out there and what the clinical indications are for these options or interventions, and how we can incorporate them into clinical practice. So my first question to you would be, what are the contact lens what are the contact lens options available for myopia control out there?
Yeah, so I think I can share with you about my experience in the States. And so to start out, I think orthokeratology is one of the most effective intervention among all different contact lens modality. And in fact, ortho-K is my daily bread and butter, and I do this every single day. And so I still feel like ortho-K is one of the most effective and also one of the most rewarding experience for both, for me as a practitioner, and also for patient and parent as well. Because as we all know, ortho-K works by using a corneal reshaping technique in order to help the patient see well during daytime. While they're wearing the lenses, all the magical things happen when they're sleeping. By the time they wake up in the morning, they're able to see well and function well, enjoy all the daily activities. And I think that is one of the most magical and rewarding experience for young kids. And besides ortho-K, we also dispense soft lenses in a multifocal fashion. There are many different types of multifocal lenses in the market, but specifically the type of multifocal lens that we're using for myopia management is primarily MySight from CooperVision, and also Natural View multifocal lenses from BTI. Those are the two main products that is currently available in the States. And in some cases, depends on the level of astigmatism patients have. We do have other patients doing the multifocal toric design in order to customize the prescription for astigmatism. And those are the two main category of contact lens modality for myopia management.
So let's start off with orthokeratology. What are the indications for you to pick a patient going into ortho-K versus MySight versus multifocal lenses?
I think the first factor or criteria we're looking at is the age of onset. And because studies have found that the younger the kids start having myopia, the more likely they will have further progression in the long run. The second thing we're looking at is the family history, whether one or both parents are being myopic. And if both parents are being myopic, they will be having at least 30 to 40% chance higher risk of further progression, or even developing other vision-threatening complications, such as myopic maculopathy. And besides these two factors, we also look into the environmental changes, how the patients interact with the surroundings. For someone who are not very outdoor person, or just not being engaged in outdoor activities, most likely they were spending more time inside. And some studies have found that indoor time or just the extent of near work will actually be associated with the further changes of myopia progression. So these major three risk factors are my general consideration, whether or not patient can start with ortho-K lenses or soft lenses in general.
Do you consider the degree of myopia also the astigmatism?
Yeah, so definitely the refractive error at onset is definitely critical to determine whether or not patient can wear ortho-K lenses. And again, depends on the criteria. At least in the United States, we are seeing that patient under -5 or less of myopia tend to do well with ortho-K. And anything above -5 or higher tend to be as an off-label application. And at least in the United States, FDA does not approve ortho-K use for myopia management 10 years ago. But recently, we have seen that there's a couple companies such as Johnson & Johnson Vision have recently introduced a new product called the Ability. It is also one of the newer version of ortho-K that have shown to be effective in slowing down myopia progression, particularly for the use of myopia management. But prior to that, we also have a product from CooperVision that had also served a similar need as well.
All right, so I'm going to take you back a bit. Aside from the refractive error and the benchmark being about -5, what the FDA has approved, before now, having astigmatism greater than 1.5 used to be sort of as a contraindication for myopia management. Do you still follow that rule, or have you transcended into doing toric orthokeratology because of the newer softwares and empirical fitting available?
Yeah, so when it comes to the level of astigmatism or toricity on the cornea, it's definitely one of the major risk factors to determine, whether patient is more suitable for ortho-K versus soft multifocal lenses. But keep in mind, soft lenses, at least in the market right now, does not really serve patient with a high amount of astigmatism. So in my patient, usually they will still be using ortho-K as the first primary modality for treating myopia and astigmatism. But the message here is not to do with the absolute level of astigmatism. It's more to do with the ratio between the level of myopia and the level of refractive astigmatism. I typically want to have patient having a 3:1 or higher ratio to start with ortho-K. If someone having a 1:1 ratio between myopia and astigmatism, most likely those patients may not be doing as good with ortho-K.
So are there any tips that you can share regarding fitting ortho-K for myopia control? For example, tips from topography, tips from the elevation data, tips from customizing the lens, maybe the back optic zone diameter specific to myopia management versus fitting orthokeratology in an adult population?
Yeah, so that's a really good question. I think we can talk about this topic for another session, but I just give you a nutshell about what we know so far about ortho-K design. So I think the first thing we're actually interested in knowing more about is the optic zone size. And I think we have been hearing a lot about different discussion about like whether we should have a smaller optic zone size to deliver better effectiveness for myopia management. I think the majority of cases they are, having a smaller optic zone size tend to allow more mid-peripheral defocus because that's the theory that we are mostly abide to. And having the peripheral defocus from ortho-K will be able to help patient deliver better defocusing system for the eye. So therefore, we're able to show better effectiveness in slowing down axial elongation. But this data is not conclusive or unanimous, because there are other studies showing that different optic zone size also deliver similar or comparable treatment outcome. So at this time, having optic zone size as an interest or the topic of interest is something that we're still knowing a bit, but not to the full extent. In terms of topography, you're mentioning about taking good topography is really key for having a good success for, especially for patient fitting ortho-K lenses, because without topography, we're not able to capture the full corneal shape, and therefore we could have miscalculate or even make the data skew over time, and you're not able to have a good data in the long run. So patient will also be suffering from either lens decentration or lens discomfort over time, just because we're not able to appreciate the whole corneal shape for fitting the ortho-K. And I think those are the two main area of interest that we're looking into when it comes to lens design.
Okay. You find that you have to repeat topography testing to get very good central topography, especially considering you're dealing with kids, because they might find it difficult to stay stable sometimes. It's difficult to get them to stay still for the examination. Do you find you have to repeat the testing several times? Are there any tricks or tips you could share, or is there any specific type of topographer that you feel may work better for kids compared to other topographers?
Yeah, so I think depends on the demographic condition of serving. In my practice, I definitely see a lot of kids on a daily basis, and I definitely encounter similar challenges as well. Being able to keep the kids still and be able to be cooperative. So I think one tips I can share with you is, the kids just want some attention, and they want to make it fun. It's a fun experience for them to take, good pictures, topography. I think one thing that helped me is that, I try to do as a game. For example, taking topography is more like, a shooting game, or having a staring contest. Having the clinician to be able to engage with the kid this way would help them, prolong the attention span. Otherwise, they will keep losing focus or not be able to, fixate a target that you want them to. So I think that's one tips I can offer. Another thing is that because the kids generally have a pretty short stature, so you want them to stand up. And then sometime if parents are around, you may also want to get parents to be involved, ask them to bring the kid towards the camera, be able to get a better image. Because this is the process that's not a one-man show. We all have to be involved in order to get good picture. So I think that's a little fun game, but also it could be challenging sometimes.
All right. Thanks so much for that tip. Now let's go into research a bit regarding orthokeratology. Considering the publications out there or the research that's been done so far on orthokeratology for myopia control, can you discuss some of these options that you may have, some of these studies that you may have incorporated into clinical practice? Is there anyone that comes to mind in particular, or anything you want to share from research that you incorporate into orthokeratology?
Okay, yeah. So in terms of the research realm, I think a couple of things that come up in my mind is that we all want to do the best to help correct patients' vision to the full extent. But sometimes ortho-K for myopia management is not mainly for vision correction. I think we just need to bring the message across before we start the ortho-K for patient. I think that will actually help set the realistic expectation for patient and the parent as well. Otherwise, they would feel disappointed whenever they cannot see 20/20. That's the first thing or rule of thumb that I generally bring it to my patient. And the second thing is that, when we see patient having high myopia, most clinicians may not be very willing or actually hesitant to proceed with high myo. But number of studies, especially the one done in Hong Kong by Pauline Cho and her colleague, they found that partial correction for ortho-K is actually pretty still effective to slow down myopia progression. So you don't necessarily have to correct the patient to 20/20 in order to get the right treatment. In fact, partial correction along with single vision correction during daytime will still be helpful in slowing down the axial length elongation. And I think more recently, we are seeing more research being done. As I said earlier, it's about the optic zone size. And there's been a lot of discussion and controversy about this topic. So I think, this discussion can be going on and on and on. But I think more and more research are showing that, if we're able to reduce the amount of optic zone size, the level of peripheral defocus can also be optimized. Therefore, we're able to slow down the axial length elongation.
Now, considering slowing down, because the essence of fitting these lenses for myopia management is to get the myopia progression under control and slow it down. Aside from cycloplegic refraction, how big a role do you think axial length measurement plays in myopia management, especially when we're discussing orthokeratology?
So the question is, besides cycloplegic refraction, sorry, what's the second part?
So aside from cycloplegic refraction in monitoring myopia progression, what role, how big a role does measurement of axial length play in orthokeratology for myopia management?
Yeah, so that's a great question. I think depends on where clinicians are practicing, even in other states. Not every doctor are having the optical biometry in order to measure axial length. So I've been fortunate enough to be able to do it on a daily basis, and that's actually one of the gold standard for practitioner to adopt. Because without axial length, especially for patients doing orthokeratology, the refractive error is not going to be measurable just because they have been well corrected while they're sleeping with the lenses. So refractive error is definitely not something we can gauge, for a patient with ortho-K. Rather, axial length is one of the pretty golden parameter for gauging, how we can measure the treatment progress, whether we should stay with the same treatment protocol or we have to modify it, in a different way. For instance, we expect a kid to grow on an average of 0.1 to 0.2 millimeter per year. And if we're just basing on the refractive error, we're not able to know how much growth, or in terms of the eyeball growth, to expand. So by having the biometry measuring the axial length, we're able to even measure it as accurate as the 0.001 millimeter in size. That will help us understand how we can gauge the overall treatment in the long run.
Thank you so much. Now, in this part of the world, again, optical biometers generally, I think, are more expensive than the ultrasound biometer. I'm not sure if you've had experience using the ultrasound biometer in myopia management. Have you?
Yes, I did. Actually, when I started with myopia management clinic, I started with the A-scan, the portable A-scan, to do the ultrasound for axial length measurement. But as we all know, having a probe directly onto the kid's eye is not easy and also not very favorable. We first have to do topical anesthetic for the young kid before we do anything. And also mentally, we have to prepare the kid that, we have to put something slightly on the front part of the eye. Some kid would just kind of, step back or being apprehensive. So more importantly, clinically, we're not seeing, very reliable data using axial length measurement by the A-scan, because it's a lot of variability. If the patient are fidgety or very having unstable fixation, you're not able to get reliable measurement. So as time goes by, we're able to get a new measurement by more standalone biometry that will actually have a non-contact area, be able to measure the size of the eye without touching the patient's eyes at all. And it's also tear film independent, so patient can blink, or even have someone having dry eye issue, the result would be less likely to be affected by that.
Thank you so much. Now let's move to multifocal contact lens options. In the area where I practice, my sight lenses, like I said before, are not widely available. So I find myself using more center distance multifocal lenses, like the one out of the Blink study and the Blink 2 study. So using the high ad and all that. Now, can you tell us a bit about the MySight lenses, the ones you prescribe? What are the principles they're designed on? What do they work based on? Just give us a brief information about the MySight lenses or the multifocal lenses you use for myopia control.
Yeah, so from what I know so far, this product, MySight multifocal lenses, are making use of the dual focus multifocal design. So they have a center distance treatment zone for correcting distance acuity. And then in the mid-periphery, they have an alternating dual focus, meaning they have distance and then peripheral plus, and then putting distance back again. So that way we are able to send the eye and the brain a simultaneous signal for both distance and near. And that near, what I mean by that is the peripheral plus. And having the plus for a kid is not mainly for seeing up close. It's mainly to just kind of disrupt the pattern of how they receive the optical signal. And by having multiple peripheral plus power, we're able to induce peripheral myopic defocus. Therefore, we're able to help mitigate the overall axial elongation. And I've been using this product for about a year or so, just because it's been recently launched in the States. And the result has been pretty successful and remarkable. A lot of my patients actually have shown us no signs of axial elongation, and they are also very comfortable with the lenses. Distance vision acuity has remained pretty steady over time. And even a patient having long days of studying or after school activity, they generally have no complaint. And the funny thing is that patient doesn't even, they were aware of the lenses being in there after a whole day. That's how comfortable the lenses has been. So based on patients' feedback and everything, I think this product has been working really well for my patients so far.
Well, thank you so much. Now, you mentioned a term while giving your last answer, peripheral defocus. Now, this seems to be a recurring term used in myopia control or myopia literature. Can you briefly tell us about peripheral defocus and how it relates to myopia and myopia progression, and how these strategies or how this term has been incorporated into forming strategies for myopia management?
Yeah, so I think in order to understand, peripheral defocus, we have to take a step back and to understand what single vision conventional type of lenses works for our patient. For young kid back in the old days, we just simply prescribe a pair of glasses. They're single vision, no signs of multifocal design in the glasses. And what it does using single vision lenses is basically to correct the focal point at the right focus of the macula. But we found that having single vision lenses can also generate or induce some sort of hyperopic defocus. The peripheral light ray will actually being projected at the back of the retina. That means it's not really focused at the retina, but right behind the retina. As a result, the eye will actually be induced to further elongating posteriorly. That's how myopia drives axial elongation. So once we understand, peripheral hyperopic defocus, how it deter the chance of myopia management, we need to alter the signal in order to bring the signal back from behind the retina to in front of retina. That's what we call the myopic defocus. By inducing myopic defocus, we're able to generate a different type of optical signal for the eye in order to help stabilize the axial length changes. So that leads to the term that I use often is called a hyperopic defocus. That means by having orthokeratology lenses or soft multifocal lenses, they're doing something very similarly, but just by different mechanism. But the main goal is to deliver some sort of peripheral myopic defocus within the retina or in front of the retina in order to generate optimal signal to slow down the axial length elongation.
So thanks for that explanation. Now, do you see any difference in visual quality in your patients who you fit with orthokeratology versus multifocal lenses? Is there any difference in the quality of vision vis-a-vis coming from an era of single vision lenses for vision correction? Do you see any quality in vision? I know some papers report changes in high contrast acuity or low contrast acuity or contrast sensitivity, but in clinical practice, do you find that kids notice these differences?
Yeah, so from a functional perspective, I think patient using ortho-K lenses, if you are doing well with the initial design, most likely they will have generally a slightly better optical quality, mainly because there's nothing on the eye during the day. They're able to maintain good vision, but the potential changes that they may experience is that, the vision could slowly wind down towards the end of the day. So if the day is just getting longer for them, they didn't have good sleeping habit, their vision could be a little bit blurry towards the evening. That could be the downside of using ortho-K lenses. But on the other hand, if patient having soft multifocal lenses, they generally may have good vision, for most of the time, but they may have, they would encounter some sort of potential changes with the lenses just because the multifocal lenses, and it takes time for them to adapt to multifocal. Some kid may experience some sort of halo, or they may have some fluctuation in the vision, and quality of vision may not always be steady throughout the whole day. So especially for patients suffering from dry eye, even though it's relatively uncommon for young kids, patients do need to remind about having eye drops, lubricant, artificial tears in order to help the vision to be more sustainable over time.
Thank you. Now let's talk about the elephant in the room. Cost for this treatment. Now, myopia management obviously is more expensive compared to just prescribing single vision lenses if you're looking at the financial cost. Although if we look at the point from preventive care, the fact that you're going to be preventing certain complications in future, it's worth the money being spent. But how are you able to factor in cost as an issue? Do you, I'm talking in terms of your practice now, do you have a payment plan for certain patients, insurance coverage? Also, the fact that I practice in Africa, not everybody, I'm privileged to practice in the capital where you have some patients who may be able to afford some of these treatment options, but a lot of times there are still patients who cannot afford these options and who you have to resort to other options with lesser efficacy. So how do you factor cost management into this?
Yeah, so again, that could be a question more demographic based. In my patient base, at least in my area, most people come from an affluent area. And so they definitely have some expectation in terms of myopia management. And I usually use an example of like having braces, dental care, and those models seems to be pretty resonate to patient, and parent understand how much it costs for a piece of braces or Invisalign. But relatively, I think myopia management in general is still pretty foreign for majority of our patients, and not everyone understand what it entails and why does it cost as much as a dental care. So I think the way we approach this is try to develop the value of myopia management rather than sticking into like how much it costs per lens or you know, why does it cost so much for myopia management? It's not about just the cost. It's about how to translate the cost into a value. If once the patient understands the value of treating myopia is to prevent lifelong serious vision problem, they actually understand, you know, okay, this is a long-term investment for my kids. And I'll definitely be more inclined to making this investment, you know, no matter, you know, this may not be covered by insurance in the States, but most likely they would be able to appreciate, all right, this is something that is, you know, doing something in the long run. Did I answer the question?
Yes, we did. Yes, we did. Thank you so much for that answer. So we've talked a lot about orthokeratology, multifocal lenses. Do you find that sometimes you have to do combination therapy for these myopic patients, maybe with low-dose atropine or with any other strategy, spectacles, anything?
Yeah, so I think I can share with you two major examples as a case study. You know, some patient I've seen, if they come into the clinic first consult for myopia management, 6 or 7 year old, having two myopic parents, and both parents are being very myopic, over -5, and kids are being indoor all day long. Okay, I consider this type of patient are relatively high risk for myopia progression. So in that case, depends on the preference and also the availability. Some kids may not be able to do lenses right away. And then I'll typically starting with topical atropine drops to get them started, get them acquainted to the idea of having something touching the eye. And then if kids are just being more receptive, more cooperative, I would employ the idea of using maybe soft lenses or combined with ortho-K lenses as the contact lens modality. So I do have patients, if they're a relatively high risk level, I do recommend starting with combined treatment. And most likely from the literature that I found so far, combined treatment do works slightly better compared to monotherapy.
All right, thank you so much. Is there any, although this podcast is specific to cornea and contact lens, but is there any concentration of atropine that you favor?
About atropine, you said?
Yeah, is there any concentration of atropine that you favor?
Yeah, so based on the latest clinical literature, we know that atropine can be done as low as 0.01%, but that was probably the outdated information. We typically don't recommend clinicians to do 0.01% for young kids, especially if they're doing as a mono treatment. It's not going to be working as effective as someone doing a higher concentration. Typically, we start patient with a 0.025%. And then in some cases, like what I said earlier, some patient at high risk level, I have to start them with a 0.05% at a higher strength in order to get the optical treatment outcome.
So thank you so much, and thank you for creating the time today. The last question. What do you consider the future of myopia management in terms of contact lenses or contact lens options? What do you think is the future of myopia management in that regard?
Yeah, so that question really affects the whole profession as a whole. And I think right now, even though we are starting to get the momentum going for the topic of myopia management, I'm glad to see that more and more practitioners are asking me questions or having the willingness or the interest of getting into this field. But I think I think we're still lagging behind in the States compared to most Asian countries, because I have a lot of practitioner colleagues who practice in Asia. They already have tons of knowledge about ortho-K, and they even have the opportunity to prescribe, spectacle specifically for myopia management. So that is something that we are still waiting and envious in the States. But I think, to answer the question, I think the future of myopia management, in my opinion, is pretty good and promising. And we're seeing more and more company and technology are just getting into speed. We're able to deliver the most optimal service for patient. And we're also seeing the quality of vision and the quality of treatment is getting better and better. So I think, in the next 5 or 10 years or so, hopefully at some point, myopia management will become a household name. And we don't have to spend much time on, explaining what myopia is about and how we can treat myopia in general, because it's going to be, a big topic. More and more parents are going to be aware of this service for young kids. And I think as a profession, we also want to grow, gradually. We just don't want to stick with the same dogma about just prescribing single vision lenses or doing the same thing over and over again. Even though they're important for helping patients, some type of patient correcting the vision, but it's not going to be the best treatment for them. All right, so I think having myopia management for young kids is definitely something. I think they deserve the opportunity to know about this service, regardless of whether they take it or not. But I'm really optimistic about the future of optometry, and I hope that more clinicians, wherever you're practicing, and I hope that this would resonate with your practice, and hopefully you'll get yourself started with this idea.
Thank you so much, Dr. Chan, for having us, for being my guest today. Thank you for being here and sharing your experience with us. Thank you so much.
Thank you so much for having me.